Hello, everybody, and welcome to episode 2 of the Bad EM podcast. I'm your host, Daniel Still, and this is a podcast where we discuss the bigger picture of emergency medicine in South Africa and Africa. Bad EM stands for Brave African Discussions in Emergency Medicine. If you haven't listened to our first episode yet, hop on over and go and have a listen to that. Please also note that it's in 2 parts, so don't miss out on the good stuff in part 2. As always, the views expressed do not represent any institutions that my guests represent and are purely personal. In this month's episode, I chat to Professor Clint Hendrikse, who is the head of division of emergency medicine at the University of Cape Town. In this episode, we chat about research and how it needs to be adapted to a low middle income setting. We also chat about how emergency medicine fits into the South African healthcare system and the benefit it provides for everybody else. And we also discuss how to bridge the gap and fix communication between different departments in South African medicine: clinical departments, academic departments, service clinicians, and policymakers, and how to teach communication skills to undergraduates and all other levels of South African healthcare workers to try and get us all on the same page. Without further ado, let's get going. Hi Clint, could you start by introducing yourself and giving us a brief rundown of your professional career so far?
Thank you. So, I'm Clint. I'm an emergency physician that born and bred in Stellenbosch. I did my undergrad at the University of Stellenbosch and then went to the Eastern Cape for my internship and community service in the Port Elizabeth. And I think that's where I got exposed to acute care, let me not say emergency medicine. And that's where I got my initial interest. And thereafter I went to Ireland and worked in 2 different settings there, in a district level hospital and then in an acute care, urgent care setting. And that's when I realized that I wanted to do emergency medicine. I became an emergency medicine registrar shortly thereafter. And once I qualified as a EM physician, I worked at Mitchells Plain Hospital for 8 years. Mitchells Plain Hospital is the busiest emergency center in the Western Cape, and I have fond memories. And since last year, 1st of Jan, I have been the head of division here at University of Cape Town for emergency medicine. And part of a very dynamic team that makes a lot of difference. And my perception of what my purpose is, or my vision, has changed so many times during my short career. But currently, I see myself as someone trying to improve health outcomes for patients with emergency needs, but specifically those where there are inequities and those where access to care is a problem.
I know that one of your big passions is research. How do we approach research and policy that is made in high income settings and use it in a constructive way and an equitable way in a low resource setting like South Africa?
So evidence-based medicine, let me start there, is slightly differently practiced in low middle income countries. It's slightly more complex. So it's a combination of the best evidence that we have, combined with the provider expertise, and then combined with the patient values and expectations. And I must admit that in low middle income countries, we don't have good evidence for most things pertaining to emergency care. There's evidence is very limited, and we find ourselves in a position where we have adopted most of the guidelines and evidence from high income countries. And more often than not, it's not applicable to our setting. So it becomes quite difficult. So we find ourselves in a situation where the provider expertise, that component of evidence-based medicine, usually dominates the decision-making, and it's informed by the evidence. So it's evidence-informed decision-making that's driven by provider expertise. And that's how I could summarize decisions on the emergency care platform. The problem with that is it makes standardization very, very difficult. Another thing that I think we should talk about is the value of research in our setting. What I've learned during the last couple of years is that if we want to improve anything, it's it takes a lot more than just research, a lot more than just good quality research. Research is a component that informs the improvement process. And if we ask ourselves, for example, how do we improve the outcomes of patients for a specific condition? The best way to tackle that is to firstly define the problem, and that's where I usually find the most difficult to do is to define the problem. What is it that we actually want to achieve? So to define the problem, and then to unpack that problem, to spend time in unpacking the problem and asking ourselves, is it a problem with policy? Is it a problem with training, education? Is there a gap in the science, etc.? Is it a problem with compliance and so on? And the gaps in science is where the research would come in. And another point that I want to make with regards to improving health systems with research, doing research in our silo as within emergency care or in emergency centers only also may not be the best outcome. Looking at a patient's health outcomes, looking at the pathway to care, the care pathway of a patient probably will provide the best outcome. So what I mean by that, so from the time of the onset of symptoms right to the end where the rehabilitation ends. So for example, if we look at stroke research, if we have a very siloed approach, if we look at it from a neurology point of view, there's a lot of research in lysis, etc., etc. If we look at it from an emergency medicine point of view, it's quick access, quick triage, quick identification so that they can get lysis, etc. If you look at it on a systems-based or on a care pathway-based approach, you will notice that quite a lot of patients with strokes don't even reach the hospital. And those that reach the hospital, there are quite a lot of delays from the time of symptom onset until they actually reach the hospital. So the patients that benefit from lysis is a very, very small proportion of the burden of stroke in our population. And so only when you look at it from a longitudinal point of view will you notice where the research or where your input would make the most impact. And that is something that we need to move towards. So it has to be a coordinated process, and the question needs to be right. The question is, how do you improve stroke outcomes, not how do you get patients to lysis quicker. And that's so there's a couple of fundamental differences in how research should happen. Number one, it has to happen within improvement continuum, which takes into consideration education, training, policy, etc., and the science point of view. And number two, it's probably better looking at it on a longitudinal way to ensure that we get the correct outcomes.
So basically trying to adopt first world medicine research into a third world might actually lead to more harm than good, because we're not going to achieve it in a lot of cases. And if we don't achieve it, it will lead to, not only for the patient, but for the healthcare provider, a lot of stress and frustration and stressful phone calls and trying to rush someone off for a CT scan that is either going to take too long or not be beneficial or miss any windows of intervention. So it's actually the wrong thing to do to start with.
So I do agree. I do agree with you. I think that treatment and improvement has been very siloed at the moment. We've been doing it in silos. We're trying to do what's best according to our perceptions in emergency medicine while the patient is in the emergency center. The medicine department is doing what they think is best with regards to their perceived outcomes. EMS is doing the best according to their perceived outcomes, but it's very difficult to really understand the cost benefit of our interventions if you don't look at it across the spectrum. And what we've done by adopting high income country guidelines and evidence into our practice, we have most likely created unachievable expectations or unrealistic expectations. And as you said, this can result, number one, in increased health expenditures and can actually worsen patient care. And if you ask yourself the question, specifically from an emergency medicine point of view, which we know is a resource-intensive specialization, how much money can we spend on one patient? For example, can we justify spending 20,000 Rand on one patient, on each patient requiring CPR and then ICU care, etc., even if the outcomes is extremely poor.
And you can prognostify that from the beginning.
From the beginning. So if our evidence suggests that out of hospital cardiac arrest, for example, have extremely poor outcomes, close to 0%. So the question is, can you justify in our fiscal climate all the resources that we are utilizing? And that includes training and education and all that, to achieve something that's probably unachievable, but it reflects an expectation that we have adopted from a different health setting.
Yeah.
So it does pose quite a few questions with regards to what should we be doing, and that speaks to our identity and what we perceive emergency medicine to be, and that is a very, very difficult conversation that is not accepted by many.
And could you just elaborate on that a bit? It's something I've thought about quite a lot, because in emergency medicine, we often sort of get annoyed by non-emergency cases and everyone pitching up and et cetera. But in terms of the actual emergencies that pitch up, a lot of them are hugely burdensome, are hugely resource intensive, like you said, the sort of cardiac arrest, the polytrauma, the aortic dissection that you read about on the latest EM cases thing, and from a realistic standpoint, our job is actually triage of patients and sort of getting the best outcome for every patient that comes through our door. And we are the one skill that you learn as an emergency medicine doctor, especially in a low resource setting, is how to risk stratify patients, who needs what and when, and how urgently do they need it, what workup do they need and when do they need it. And you learn how to redirect patients to appropriate care. And that sounds bad, and it sounds like a thankless job or a meaningless job, but we are, as the emergency medicine doctor, as the decision maker, in a very crucial point in a patient's journey of their healthcare. You're making a very important decision, and that decision can be the pivot in terms of good outcome or bad outcome. So in terms of our job description or our perception of what we do in emergency medicine and who does it, and a lot of people say when you tell them that you do emergency medicine, that must be so exciting and that must be adrenaline all the time, and it's actually pretty much primary care with a splash of adrenaline in between. Very seldomly, actually, the more you go on. How would you see our speciality going forward?
So this is a difficult question, and I think the fiscal climate that we're in has actually forced us to rethink quite a lot of what we do. They say there's nothing like a crisis to get you to rethink and redesign things. So there's an interesting concept in emergency care, is how much is about the individual patient and how much is about the population outcomes. What are we trying to achieve with emergency medicine or emergency care provision? Are we trying to improve health outcomes of a population or that of a patient? And it's a very difficult discussion. Once again, everything needs to be coordinated. If we talk about resources that we implement, this needs to take into consideration the population health and the budget, the health budget of the population, etc. How do we justify spending a lot of resources on one patient versus taking it away from a different cohort of patients that may have benefited from it differently? And that's a very difficult question, but it's something that we probably need to ask ourselves more. If our role is to improve health outcomes, it requires a much bigger coordinated process and collaborative effect. I'm going to come back to your question about what I think our role is. So emergency medicine has evolved during the last 2 decades into the beast that it is currently. And many factors have affected that evolution. Not all good, not all bad. The health system, if you look at access to care at the moment, there are definite gaps in the health system. If you look at how can patients access health care. In the public sector, they've got very, very few options. They have the 24-hour emergency centers and they've got the primary healthcare sector. And that's essentially how they access healthcare. The only 24/7 service available for patients is emergency medicine in the larger hospitals. If you look at the private sector, there are pharmacies that they can access directly. There's GPs, there are different fora, there's even telephonic consultations, etc., etc. So they've got a much broader spectrum of options. So emergency medicine has evolved into the speciality that manages unscheduled healthcare. And we know that not all unscheduled healthcare needs require emergency medicine
intervention or emergency intervention.
Exactly. Yeah. So we have evolved into the department or the area, a geographical area that manages everyone that comes into a facility, that presents into a facility, all unscheduled care. And much of this is as a result of a lack of access elsewhere for these patients. It is something that we've assumed to our own detriment. And now, with the capacity demand mismatch growing bigger and bigger, we find ourselves struggling to perform our core duty, which is treating the emergencies.
Yeah, so our perceived core duties.
Our perceived core duties. So coming back to your main question, if you look at what value, it's about what value can emergency medicine, emergency care bring to our health system. If you look at that, I see ourselves as the generalists of hospitals. Similarly to family physicians being the generalist of the primary healthcare sector and the community health sector. And the one benefit that we have is because of our knowledge, because of our insight of the health system, the general health system, and the resources, and our unique position in the health system, we have the competency, the skill to dictate the movement of patients and dictate the resources that patients use, as you mentioned earlier on. So we dictate patient movement and the resources that they require in the beginning, and that creates a sense of order and stability in the health system. And this is something that is not often spoken about, but we create stability in health facilities by dictating patient movements and resource utilization.
Yeah.
And we act as a buffer between those who present to facilities and the health systems, as well as those waiting on the ward system.
Or the outpatient clinics.
Or the outpatient clinics. I think another big function or value of emergency care, emergency medicine and emergency care provision is that in the broader health system, we create stability from a global health point of view. So with regards to pandemics and outbreaks and other insults, I'm not saying we act as the buffer to the health system, but we create stability in there. So to summarize, we've got a unique systems oversight and a broad clinical scope to be able to make those tough decisions that dictate patients' movements and resource allocation, etc. Yeah. And our second big priority or value adding benefit is the fact that we can stabilize and treat the acutely ill, specifically those with reversible causes. If you look at the health system at the moment and how it's designed around emergency care provision, it is much different to what it is supposed to look like.
Yeah, and the potential it could look like.
And the potential. And I think for us moving forward, specifically in this fiscal climate, we have to focus on what value we provide to the health system and to patients, and then redesign the health system to suit that. And perhaps move away from filling gaps in the health system, because as we noted, that dilutes our value adding capabilities, and it actually takes us away from our core function. It makes us less efficient with managing the acutely ill.
I think one thing to just add there is we underestimate sometimes the value that we do add in non-intervention for a patient that presents to an emergency unit. And a lot of people who work in emergency units, I think, don't realize or underestimate the value that they've given to a patient just by reassuring them or sort of giving them an appropriate workup, outpatient workup or outpatient follow-up plan, or just by simple reassurance. Your baby looks fine. I know you were very concerned, but from my professional opinion, you can watch it closely at home, and if this or this or this happens, then by all means come back. But that in itself, that reassurance, that advice, is a hugely beneficial part of the healthcare system.
100%. And why if I look at training of emergency medicine or training of those concepts, let's rather move away. If I look at the training of the competencies that you describe now, it's not very well taught in other disciplines. The ability to risk stratify, the ability to decide when to discharge or not. There are certain skills and competencies that are quite unique to emergency medicine. Unfortunately, it's not trained very well in undergrad at the moment. So our emergency medicine platform, our training platform for undergrads, is not well developed. It's not standardized yet. And some universities offer emergency programs to undergrad training, and some have very, very limited exposure, unfortunately. And when you delve a little bit further into the training of undergrads, we are trained in silos. We are trained in medicine, and then we are trained in emergency medicine, and then we are trained in orthopedics, and then rehab. We lack, it creates the expectation that care provision is also siloed
and compartmentalized.
And that creates a barrier with the student or the future healthcare provider to understand the health system and the pathway of the path of care to be able to make those decisions. So the way we train is in essence also a barrier to making those tough decisions, because you need a level of insight and understanding of the health system. Secondly, because we are trained in a tertiary environment, which is the furthest away from community-based medicine and district-level care, where the burden of emergency care is being provided. This creates a further barrier, because being trained in an academic environment, the priorities is a lot different to when you are trained or when you work in a district level or community level hospital. Academic environments, the focus is completely different. The resource allocation and is a lot different to what we have. And for doctors to make that, to realize that, takes a couple of years. It takes a little bit of experience and a little bit of guidance, and that is where emergency medicine fills a gap at the moment. Also, and I think this is also an important point, when you talk about health outcomes, the determinants of health, of which there are social determinants, economical determinants, etc., plays a far bigger role in health outcomes than the medical interventions that we do.
Yes, yeah.
Those determinants of health are not taught very well in undergrad, etc., etc., and that provides the necessary knowledge and understanding and the insight to also make decisions about discharges and risk stratification, etc.
And the value added, or the perception of value of a good service.
100%. And I think that in emergency medicine and emergency centers, etc., we are, because we are at the interface between the public and the health system, facility-based health system, we are forced to understand and these determinants and incorporate it into our treatment plans or care pathways. And I think that's why we have a lot more insight on these decisions because of where we work.
To sort of change the topic a bit, in terms of what you were saying about as an emergency medicine providers, we are often faced with the decisions about the interface between primary and tertiary care. Let's talk a little bit about the interpersonal relationships between doctors at all of those levels. All right. I think that we are in a bit of a unique situation in that when we receive a lot of referrals from primary care, as well as having to make a lot of referrals to tertiary care. And I think that gives us a bit of humility and insight in how to receive and how to make referrals with understanding and non-obstructive behavior. And a personal observation, which is again anecdotal, I don't think that this has been studied, it might have been, is the higher up the food chain in terms of the, not necessarily your expertise or knowledge, but in terms of the size of the facility you work in, the more obstructive people tend to become. How do we alleviate that? How do we get everybody on the same page? And I think research and shared data and shared knowledge can go a long way. But how can we spread more of a sort of accommodating environment between doctors?
I think part of the answer to this question lies in the way we train, and I've already mentioned that our training is compartmentalized, and within that compartment, whether it's medicine, emergency medicine, we try to do the best according to what our expectations and our perception of good health is within that. It's very difficult to see the longitudinal journey and the actual outcomes of patients by being trained in a compartment and practicing within a compartment. So the first thing I think that is that may help with this is the concept of care pathways. We should invest in looking at the care pathway of a patient as opposed to a compartmentalized approach. And this automatically will involve everyone from the onset of symptoms, EMS, primary health care, the district health system, maybe regional and tertiary. And only then will we be able to understand the value that we actually bring. And only then will we be able to understand each other's value in the different sectors and our roles in the different sectors. So focusing on care pathways instead of compartmentalizing discussions.
In terms of, you said sort of what is needed in this facility may not be needed in that facility. Sometimes new research and new data and new ideas can actually be applied to various different facilities, but are not, because the way in which things are done at a certain hospital through different teaching, different leadership, different when people say, oh, it's just always been done like that here, for example. But then somebody who's had experience somewhere else, either in training or students or whenever they were pick up ideas or pick up knowledge. For a clinical example, inotropes through a peripheral IV line. A lot of research suggests that that's perfectly fine, and it saves a primary care provider a lot of time not having to put up a central line. But in certain settings, that is a big no-no, and God forbid that you give inotrope through a peripheral line. Another example is like waiting for creatinines before CT scans. A lot of places that's recognized as null and void. Radiologists think it's completely fine, and in some places it's a huge no-no. And those are at different places in the same province, in the same health system, and it causes a lot of interpersonal fighting, because if I've done it one way my whole sort of career, now I move to another place where someone says I can't do it like that, it causes tension. And that often comes from a sharing and a accessibility of up-to-date research and knowledge, and but it also comes from an unwillingness to access that knowledge. And so how do we make it more, how do we sort of spread ideas in a more interpersonally friendly way, put it like that? And how do we encourage change through research and accessing data?
So firstly, to answer that question, it's a multifaceted question, and then there's a lot of different ways I can answer this. From a research point of view, when it comes to knowledge translation, we're not very good at that. If you unpack the process of knowledge translation, it actually starts before you start the study. That's when you have stakeholder engagement, and whether that's the community, understanding community values or stakeholder values and stakeholder expectations, etc. So the process of knowledge translation actually starts right from the beginning of the process, the conceptualization of this research project. So we understand what are all the dynamic variables that play a role in this situation, and then you try and answer the question with your research, and then you feed back the information. So knowledge translation depends on the type of outcome. So what are we looking at, and the audience. So if the audience, for example, is students, medical students, as opposed to policymakers, your medium, your platform where the knowledge translation would be centralized around would be a lot different. So you need to understand who are the audience, and the audience depends on who are your stakeholders. So you have to do a stakeholder mapping essentially, and that is a process that probably needs to happen concurrently with the research process. Stakeholder mapping, understanding where the power lies, which stakeholders has the most influence, has the most interest. There's a way to map those. So people with high interest and high influence, those are the ones that you target. Low interest and low influence, you probably not involve at this stage. And then there's varying, the spectrum varies in between. And then you target your knowledge translation strategy towards the audience within the most appropriate platform or medium. We're not very good at that for various reasons. For example, it's my perception that in the academic sphere and the service sphere is not always aligned. And the best way to tackle this, the best way to tackle improvement is according to me, is the problem-orientated approach. You have a problem, you unpack the problem with the relevant stakeholders. For example, if the problem is critical care transfers, for example, who are the stakeholders that have an impact or have either interest or influence on this subject? Let's unpack it. What is due to what elements needs to be answered by science? What is a training or education problem? What is a policy guideline, standardization? Where does the problem lie? And then we tackle it in each of the individual concepts, bring it together, and then research in itself it's very difficult to change practice. So there has to be a coordinated improvement process that has to involve all the stakeholders or the people involved.
And the research is just one.
It's one component
of that.
Yeah, and that is difficult. And if the academic sphere and the service sphere remains apart, it's going to be very difficult to fill that gap.
Yeah.
If it's a coordinated process, say, listen, let's tackle this problem. Let's unpack it. And then each and everyone goes and do their thing and come back. That's most likely the best way to tackle these issues. So in summary, I think research has big value, and it's got a specific, very specific purpose in our improving health outcomes. But research by itself in an uncoordinated sector is carries little value.
Yes.
Yeah.
And how do we disseminate it? How do we spread good ideas to the service sector as well as to the policymakers?
Yeah. So.
And who are the policymakers? who like often people refer to protocol and policy, but when you ask them to show you one, that doesn't exist.
Yeah. So firstly, the policymakers are much closer to us than what we think. If we would have to do a stakeholder mapping of emergency care provision in the province, for example, we've got Heike Geduld, who's the provincial specialist in emergency medicine. We've got Craig Wiley, who's the director of EMS, etc. We've got key people and key leadership positions that are very, very influential and has quite a lot of influence and control over what happens. So our policymakers, or those who influence policy decisions, are much closer, much within our circle of influence, much more within our circle of influence now than about 10 years ago. So emergency medicine in general is not well represented. It is seen as a new specialty, even though we are 20 years old in 2024. It is seen as a new specialty by many, and we're not well represented in circles and committees who has the power to implement big changes. During the last 5 years, we have our representation has increased quite a bit. We are now part of the conversations. We are now in the trauma initiatives with the trauma surgeons and with the surgeons and with the nurses. We are now in the mental health sphere with the psychiatrists, etc. We are in the orthopedic and surgical sphere because they've realized that emergency care plays a big role in
who accesses their service.
Exactly. So we have our representation has increased in the last 5 years, our influence, and policymakers are a lot closer to us. So I can say and I'm happy to say that those conversations, those coordinated conversations is happening. And there are quite a lot of projects running in the background into all the different components from a service point of view, science, research, governance, education, training, etc., policy, etc. So there's quite a lot happening in the background. And I think driven by this fiscal crisis and the need for redesign and a rethink, I think we can expect a lot of change in the next 5 years.
You said earlier it takes a crisis to force change. So while we're talking about that, while we're talking about the fiscal crisis and everything, it seems that the burden on our healthcare system is increasing. It feels almost like palpably feels like almost every day there are more people, more beds needed, more decisions being made out of lack of resources than before. And I know that's a hugely different thing across the province, across the rest of the country, and across the rest of Africa. That is a hugely different ball game. But it feels like there's an overburdening of a system and an under-provision on the system's behalf. And that seems to be getting worse every day. And now when we see more people waiting, when we see the tertiary care system and the primary care system both sort of having shortcomings that are forcing people to emergency and unscheduled care, then we get things like budget cuts and staff shortages, and now we can't do this, we can't do that. what you said earlier is reassuring, but is there more of a plan? Are we doing things to sort of reevaluate this and how we work?
Yeah, so if you look at emergency care provision globally, there is a similar pattern all around the world at the moment. Waiting times in the UK is skyrocketing. The same discussions we are having is being held on all the continents. In the US,
in Canada, there are people waiting up on stretchers. Yeah, and that's the best there is.
Yeah. And
well, best in terms of our perception of quality.
100%.
Yeah.
And the demand for emergency care over the last decade had slowly but steadily increasing without the matching of resources and staffing. Crowding is a major factor globally, and even the EMS offload times is increasing, and all of that contributes to morbidity and mortality, as you know. Burnout and staff well-being is a big factor because about 60% of our staff is anticipated to have significant symptoms related to burnout. We know healthcare providers in the emergency care sphere has the worst life expectancy and very bad divorce rate as well. So from a staffing point of view as well, it's something that's not sustainable, and the staffing models are not conducive to staff well-being and long-term retention. So all of these factors increase the utility or the access, the requirement healthcare needs from an acute care point of view. And if the question is, how much staff do we need to fill the gap? I almost want to challenge it. I want to ask, will we ever be able to fill that gap? And I think we won't, because of all these dynamic factors that are out of our control. It reminds me of an interview in the week, I think, with our mayor, Jordan Lewis, where they asked him about housing. And they asked the question, will there ever come a time where all people will have access to a house? And the question, and he said no, and he said it with lots of confidence, and then he justified it by saying, we've increased the number of houses that we build per annum year on year. And he quoted a number, say it's around 6,500 or something. But he said that number at the moment is equal to the daily micro-immigration, the daily. So the per annum housing output is equal to the daily. So he says there's no doubt in his mind that if we continue like we are, we won't be able to bridge that gap ever. And I have a similar feeling to emergency care. So I think more staff, more resources is not the answer. It may plug temporary gaps. There's two things that we need to define, that we need to do. The first thing is define what is the minimum staffing levels, the minimum safe staffing levels for any environment. And that is something that we don't know at the moment. There's a lot of studying, there's a lot of research going into it at the moment, trying to define staffing models, staffing norms, and minimum staffing, safe staffing levels. So that's the first thing. Understanding what is the minimum we should be able to do to ensure a safe environment. And the second thing is the only way we're going to improve this capacity demand mismatch is a complete redesign of the health system, taking into consideration what I mentioned earlier on. What is the purpose of emergency medicine? What value do we bring to the health system? And then we design everything around that. And it's a very specific niche, and it's much different to what is currently happening.
One of the things that Almiro said in our first episode was, we're not going to solve the problem by continuing what we are currently doing, just harder. We have to change. And a lot of different countries have tried different means of change. In the UK, they've got a telephonic service, like a triage service, which works to an extent and has showed decreased demand on the emergency system, although it's still very high and the waiting times are still very long. And it also depends who is on the phone, because it's usually a triage nurse who answers the phone, and they do not have enough clout to tell someone with chest pain not to come to hospital, even if so they've got certain trigger words. In Scandinavia, I know that you have to get permission first before you go to an emergency unit. You have to either get permission from a 24-hour GP, which tend to not exist in the low income settings in South Africa. That often poses different problems. In the UK, their telephonic triage service, a lot of the patients come in demanding to be seen quicker because they've now phoned ahead, and their perception is that allows them to rush in and all the doctors must run to sort of attend to their emergency because the person on the phone said they must rush. Is there anything that we are working on in South Africa at the moment along these lines to try and make the system more efficient or work better?
So we've got quite a lot of research done by Willem Staschen and all his co-investigators on telephone triage for the pre-hospital setting. Quite substantial research in multiple languages as well. And we've reached a stage where we can move towards the implementation phase. And it's something that is going to work with the service side during the course of the year into next year. So from an EMS pre-hospital point of view, there's a lot of research, and I think there'll be a lot of changes going forward that will actually save money. From a facility-based point of view, we should invest in, we should first realize that unscheduled care does not equal emergency care.
Yeah.
And that the hospital and the health system has a role to play with regards to unscheduled care. Thirdly, we need to invest into a sorting system. So not triage. Triage says, who do we see first? Sorting means, what does this patient need? And that means a lot of resources right in the beginning of the patient care process, even before triage. Someone senior team eyeballing, and then that should activate different aspects, whether it's emergency medicine, whether it's a general medicine area, general inquiries, whether it's a booking. That should activate the other options depending on the patient's requirements and needs. So I feel pre-hospital telephonic triage, we also need to understand which patients EMS can safely discharge at the scene.
Yeah.
When the patients arrive at the hospital, we need to understand which patients can be safely discharged, and then we need to invest in the sorting process and the understanding that unscheduled care is a hospital and a health system function, not an emergency medicine function, and then get the patient. That's probably what we need to invest in.
We need to look into, and that also involves front loading
100%.
the system with more senior decision makers at the beginning. Like I said earlier
100%.
about emergency medicine, training you to be able to make difficult, quick decisions.
Yeah. 100%. Front loading is there's good evidence to suggest that there's benefit to it from a patient outcome point of view and from a health systems point of view.
Yeah. And in terms of that spread of decision making, in terms of location, and I feel like telehealth apps like Vula and apps like sort of medtech in general have a lot of potential here. But how do we decongest decision making, delocalize is a better word, decision making that is currently focused very much in urban centers and big university hospitals or hospitals attached to a university? How do we broaden that and make it more accessible in the more rural settings in South Africa, where senior advice and like sort of almost, like you said, paternalistic decision making is not so far away and so disconnected from the decision that needs to be made at the time and at the service level?
So I think there's long-term and short-term strategies that one can take to answer that. But from a community of practice point of view, it's the concept where a group of people take on challenges and try and figure out what's best for that challenge. And I think everybody on the care pathway spectrum, from EMS right until the tertiary environment, as a group, as a community, should make the decisions for that will influence the health outcomes. So that needs to be incorporated into the governance structures, etc. Instead of the central or the tertiary hospitals or the specialists who perhaps do not have the insight of the individual systems making all the decisions. That is basically what's happening at the moment. I feel family physicians are key to this process. They understand the health system, the needs, the resources, the determinants of health. They are very well positioned to coordinate these kind of discussions. But unfortunately, the power that goes along with decision making and guidelines and proposals are often nested in the tertiary or the academic environment.
But yeah, so you mentioned the community of decision making and the communication of that. I feel like the more we have in common across different hospitals and different settings, and the more people that think about this as a healthcare pathway, the easier it is to communicate with different people and different receivers and senders of referrals. For example, if you have worked in a certain hospital before, and if people know you there anecdotally, or if somebody is now rotating at a primary care facility and is referring a patient to you, it changes from, oh, this place always sends us complete rubbish and we must, and whatever, just let them come. It'll probably be an undifferentiated patient when they arrive, to, oh, I actually know so and so, they used to work here, they must know what they're doing, and the patient's probably actually sick. And that is a completely unwarranted feeling. And I feel like because of trust and communication, it makes it so much easier. If we could broaden that and make communication better, we'd end up trusting a lot of our colleagues more, which is sadly something that is not very common in South Africa. It's as soon as someone you don't know, or a hospital or institution that you are not familiar with tries to refer your patient, your hackles go up. And I feel like there are too many hackles in South Africa in healthcare at the moment.
Yeah, 100%. And linked to my previous answer, the goal of outreach, and this should be, you should with intent try and mend relationships between the two teams or between teams, and streamline care pathway discussions. I think that's the only way where we could have good communication. And there's lots of evidence that the better the communication, the better the health outcomes for patients. And we recently unpacked the role of an emergency physician or emergency clinicians as part of a process to redesign our curriculum completely. And we've come up with a set of competencies, a list of competencies, core competencies. And it reflects everything we have spoken about today: communication, leadership, teamwork, etc. Those are core competencies that came out from this process. Subsequently, in our curriculum moving forward, they will be trained and assessed. So it's not it's good if you have these skills. We've determined that they are essential to what we do. And now it will be trained and assessed. And I think that should reflect in practice.
And I think also communication to patients themselves. Like we do get training on your bedside manner and communication about a disease process and explaining a disease to a patient. That is sort of quite well done, I feel. And that has always been well done, or some better than others again. But what I don't feel like is well done is explaining the care pathway to a patient and managing expectations of care in terms of what will happen now. Between different systems, also between private care and public care. A lot of private providers have a lot of patients are somewhere in between the financial bracket that allows them private care and public care, and some of them access private care, which then turns into public care. and that is often investigation-based, scopes, CT scans, MRIs, etc. And I feel like a lot of private providers, which trained in the same institutions that we do, they don't explain to patients that, yes, we think you need a G-scope, we think you need a scan. They might not think you need a scan. They might think you need a scan, but only in 6 months' time, etc. And then there's a lot of miscommunication. Patients come to an emergency unit because they think they desperately need a scan, and then they are very disappointed with the result of their care. And that's not necessarily a quality problem. That's a communication problem.
I agree with you. I think in many ways we are our own worst enemy. We create expectations with the community, with patients that are unrealistic and that can't be met. And on an individual basis, a good example is what you just had. There's an expectation with that patient that they will get this because it is urgent. But even on a broader population base, there's this expectation that they have on the health system is much different than what the health system can provide.
Yeah, big time.
And that is arguably the biggest challenge we have, is how to bridge that gap.
And where does that come from? Does that come from TV, like watching New Amsterdam and seeing people rush into an emergency center?
I think partially, yeah. This is a tough one. We probably need to investigate, but I think it's multifactorial, because we've got the dual system, the private and the public sector system, and the private system is a fee-for-service based model. So the more we do, the more income we get. That model often leads to over-investigation and more interventions and more, etc.
And the medical aids will pay, so let's just do it.
Yeah. And that has probably contributed to this expectation that good healthcare is what is happening at the moment.
Investigation-based healthcare.
Yeah. So that contributed, and I think media has as well. And I think a lack of communication to the population of what the health system can offer. And this is something it's a very sensitive matter, but I think there's a big disconnect between what can be offered and what is expected to be offered.
One of the goals of this podcast from the start is to reassure the doctors and the other healthcare providers of South Africa, especially the ones directly in the service sphere, as opposed to the academic sphere or the research sphere or the public health sphere, that things are being done behind the scenes and things are being thought about and people are thinking about these systemic problems and ways to fix them. So is it safe to say from your perspective that is happening?
Yes, so a lot has changed during the last few years, and I can say with a lot of confidence that the vehicle for change looks a lot different now than then, and I'm confident that in the next few years there will be significant changes. From a power point of view, influence point of view, we have access to people in power that can represent us in the big decision-making bodies. And I think with the redesign and restructuring of emergency care provision, we are on track to affect change in the next few years.
Thank you so much for joining us, Clint. I really enjoyed that, and I hope our listeners did too.
It's been a pleasure. Thanks.
All right, that is all for this month's episode. As always, please get in touch at dan@badem.co.za or visit our website badem.co.za for lots of content. There's new exciting stuff to come, so please like and subscribe, and we will see you next time.